Good morning, this is Dr. Heba Ghanoum, lecturer of audiovestibular medicine, and our topic today is vertigo. Let's start by quickly revising the anatomy and physiology of the vestibular system. Vestibular system is a sensory system responsible for detecting 3 حاجات اللي هي الموشن والhead position and spatial orientation اللي هو relative to gravity. احنا we mentioned earlier that it is composed of 5 structures. membranous labyrinth طبعا situated inside the petrous bone. vestibular labyrinth أو vestibular part منها is composed of 5 structures اللي هم 3 semicircular canals, anterior, posterior and lateral, و 2 otolith organs اللي هو الutricle and the saccule، وطبعا connected to the cochlea. 3 semicircular canals are responsible for the angular acceleration, whereas the otolith organs are sensitive or respond to linear acceleration. If we start with the 3 semicircular canals, they are located perpendicular to each other at a plane of 90 degrees to each other. Each tube is responsible for detecting a certain plane of movement of the head. فاحنا we have 3 planes of movement or 3 head movements that can be detected by the semicircular canals اللي هي movement up and down movement as in head nodding، أو side to side movement as in shaking the head، أو tilting the head to the right أو to the left. يبقى these are the 3 planes of rotation أو 3 planes of movements located by the 3 semicircular canals. These tubes كل tube منهم احنا we mentioned برضو ان هي it ends with an expansion. الexpansion ده سميناه أو expansion أو dilatation سميناها the ampulla, and inside this ampulla lies the sensory epithelium أو vestibular sensory epithelium of the semicircular canals. Semicircular canals contain endolymph. When the head is rotated according to the plane of rotation of the head, a certain canal is activated. إيه اللي بيحصل؟ بيحصل movement of the endolymph inside this canal corresponding to the plane of movement اللي حصل. طيب الendolemph will move through the canal towards the ampulla. As you can see, this is a cross section inside the ampulla. It's composed of hair cells and supporting cells. At the top of each hair cells في حاجة اسمها stereocilia, and this stereocilia is embedded inside a structure called the copula. The copula is transversing أو يعني crossing the ampulla from one side to another, not allowing the passage of an endolymph. When the endolymph arrives, passes from the canal and reaches the ampulla, it causes deformity in the shape of the copula, and this causes deflection of the stereocilia. This deflection of stereocilia will activate consequently will activate هيعمل opening للion channels and release of neurotransmitters, sending the information about the plane of movement according to the activated canal. Each semicircular canal of the 3 respond best to motion in a certain plane. بس كمان adding to this, there is on the other side a coplanar pair. في pairing of the canals، يعني في on the right side and on the left side. As an example, if I turn my head to the right side هيحصل excitation للlateral right lateral semicircular canal، وكمان معاه هيحصل on the same in the same time inhibition to the left lateral semicircular canal. By this way, the brain will detect the direction of the head movement, will be able to detect in my head was rotated to the right side. By comparing ازاي؟ By comparing ان ناحية حصل فيها stimulation and the other side حصل فيه inhibition of the same canal, of the corresponding canal. What about the otolith organs, the utricle and the saccule? The utricle and saccule, we mentioned that they are responsible for linear acceleration, detecting linear acceleration. يعني they can detect backward and forward movements and can detect the gravitation forces. The structure هنا is different than the ampulla. As you can see هنا, this is the macula of the otolith organs. It is composed برضو of supporting hair cells and supporting cells. وon top في of the hair cells, on top of the hair cells في stereocilia and one kinocilium. These are embedded here in a gelatinous layer. On top of this gelatinous layer في calcium carbonate crystals that we call the otoconia. Upon head tilting, a backward tilt to the back, هيحصل shift في movement في الأوتوكونيا. هيحصل this will cause movement of the hair cells, movement of the stereocilia either towards the kinocilium or away of the kinocilium, and hence detect the plane of movement that occurred. Following the release of neurotransmitters from one of the vestibular organs, هيبقى عندنا neural signal that will travel along one of the two branches of the vestibular nerve. The vestibular nerve has two branches, the superior vestibular nerve and the inferior vestibular nerve. The superior vestibular nerve innervates the anterior and the lateral semicircular canals and the utricle, whereas the inferior vestibular nerve innervates the posterior semicircular canal and the saccule. The two branches travel and will project to the brainstem, to the pontomedullary junction, and to the cerebellum. The nerve impulses produced or elicited from the vestibular structures will travel, as we said, in the two branches of the vestibular nerve. They will project centrally to the cerebellum and to the vestibular nuclear complex in the brainstem. The vestibular nuclear complex is composed of four main nuclei. Not only أربعة، هم مش بس أربعة، هم أكتر، بس المين four nuclei هم superior والinferior medial and lateral vestibular nuclei in the brainstem located in the pons and the medulla. هيطلع منهم بقى what's known as the vestibular reflexes. هيطلع منهم various connections، يعني connections to various regions، بس أهم ثلاثة طبعا to the cerebellum, to the ocular nuclei اللي هم forming the vestibulo-ocular reflex, and to the spinal cord forming the vestibulospinal reflex. In clinical practice, assessing the vestibular function relies on a great extent on assessing the vestibular reflexes. أو بمعنى أصح assessing to the two most important reflexes اللي هما ال vestibulo-ocular reflex, ال VOR, and the vestibulospinal reflex. What's the main purpose of the vestibulo-ocular and the vestibulospinal? The vestibulo-ocular is responsible for stabilizing the image during head movement. يعني إيه؟ بيعمل rapid compensatory eye movements to maintain the stability of the image on the fovea during head rotation or head movement. What about the vestibulospinal reflex? What's the importance of vestibulospinal reflex? It maintains body posture. Maintaining body posture and maintaining the center of the body over the base of support. What about finally the vestibulo-colic reflex? This is responsible for the head position, maintaining the head position irrespective of the position of the trunk in response to or relative to gravitational forces. To sum up, what does it take to keep the body balanced? This involves three components. Involves a sensory input that's coming from the visual, vestibular, and proprioceptive systems. This is followed by central integration and comparing of these inputs inside the brain at the level of the brain. And then this is followed by generation of motor commands, generating the motor commands, whether this is to generate eye movements, or at the level of the musculoskeletal system to generate motor tasks, to perform motor tasks to keep the body posture and balance. Any disruption to one of the systems involved and previously mentioned will affect our sense of balance. Disorders of the vestibular function will result in abnormalities in both the VOR and the VSR, the vestibulo-ocular and the vestibulospinal reflexes, and this will in turn result in false or abnormal sense of motion and sense of imbalance. What is vertigo? Vertigo is the illusion of spinning. Spinning, and please concentrate on the word spinning. True vertigo يعني spinning. True vertigo يعني هنلاقي nystagmus. The problem with the vestibular patient is they cannot always explain their complaint accurately. يعني أنا عندي دوخة. Is it disequilibrium? Is it vertigo? Is it presyncope? Is it lightheadedness? What is it? It's very important to take accurate history and to know accurately ايه complaint of the patient. Vertigo يعني لازم يكون في spinning either of self or the surroundings, and this is caused by the contradictory information from the vestibular, visual and the proprioceptive systems. Okay, so we mentioned that vertigo يعني true vertigo يعني في spinning يعني I will record nystagmus. What is nystagmus? Nystagmus is defined as involuntary, rhythmic, oscillatory movements of the eye. It has two components, slow phase and fast phase, أو slow component and fast component. The slow component ديت is due to the vestibular or the brainstem activity أو abnormality, whereas the fast component هي corrective phase اللي هي cortical correction in the eye is correcting itself back to the correct position. Nystagmus is usually named by its fast component, and please note here that I'm describing أو I'm talking about the vestibular nystagmus لأن في several types of nystagmus في physiological nystagmus في several types of nystagmus فهنا I'm describing the nystagmus, the vestibular nystagmus with the slow and the fast components. This is an example of nystagmus, involuntary rhythmic eye movements, and we have to specify its direction and amplitude. Vertigo is divided into peripheral vertigo or peripheral causes of vertigo and central causes of vertigo or central vertigo. How can we differentiate between the two? The most important points اللي نقدر نعمل differentiation منها onset of the vertigo is usually paroxysmal in cases of peripheral. يعني إيه paroxysmal؟ يعني it comes in sudden attacks, whereas in central it's not. It's rarely paroxysmal. The intensity طبعا peripheral is more severe. Peripheral vertigo is more severe than the central. The duration is less in case of attacks نفسها. Duration of the attack بتكون shorter with peripheral vertigo يعني duration might be seconds in some disorders like BPPV هناخدها لسه قدام, and may extend to hours. longer durations دايما usually بتكون مع central vertigo. Induced by head position, this is not a must, but frequently it accompanies the peripheral vertigo. Nystagmus is present in cases of peripheral causes of the vertigo, whereas it might be absent with central vertigo. And when we mentioned earlier that we have to record vertigo, true vertigo, يعني we have to record nystagmus, this means that we have to record during the attack. When there is true vertigo, يعني during, if the patient is experiencing an attack of vertigo, at that time you record the nystagmus. But sometimes you examine the patient in different stages of the disease. يكون ابتدى يحصل فيها حاجة اسمها central compensation. At that time you might not be able to record the nystagmus. The nystagmus pattern in peripheral, it's unidirectional, and it is increased by loss of fixation, or actually it can be abolished by fixation, whereas in central nystagmus central vertigo النستاجمس بيكون direction changing، يعني ممكن يغير اتجاهه، والفixation مش بتأثر في الفixation، يعني visual fixation، يعني I ask the patient to fixate his vision on a target. This does not cause any change to the central vertigo. كمان في الاوتونوميك nervous system symptoms زي nausea والvomiting طبعا بتكون more evident and more pronounced مع peripheral than the central vertigo. كل ال audiological symptoms أو كل ال symptoms اللي هي related to the ear اللي هي hearing loss tinnitus طبعا بتكون evident with peripheral causes of vertigo, and it's rarely present with the central vertigo. On the other hand بقى neurological symptoms, disturbance of consciousness, ataxia الكلام ده كله بيكون evident مع the central causes of vertigo and is absent with peripheral vertigo. What are the most common causes of peripheral vestibular dysfunction or loss? These are not the only causes, but these are the most common and the most important causes of peripheral vestibular dysfunction. Vestibular neuritis, the most common benign paroxysmal positional vertigo, what we call BPPV, Meniere's disease, endolymphatic hydropes, and finally labyrinthitis. Labyrinthitis have been earlier explained with Dr. Muhammad al-Sheikh, so we will go through the first three causes: vestibular neuritis, BPPV, and Meniere's disease. Vestibular neuritis, what are the symptoms and signs or presentation of a patient with vestibular neuritis? He will present with sudden severe vertigo without hearing loss. The vertigo can last from hours up to a few days. Gait and posture are affected with tendency to fall, severe nausea and vomiting, and it might even necessitate sometimes hospitalization or hospital admission to compensate for the dehydration. Sometimes the vestibular neuritis is preceded by viral upper respiratory tract infection. Inflammation in the vestibular nerve will result in hypofunction on the affected side, and this will cause vertigo. ده معناه if I'm examining the patient during the acute stage before central compensation, I will find spontaneous nystagmus and after head shaking nystagmus. Full compensation from a severe vestibular loss can take up to months, and it's not uncommon in the patient can present بعد vestibular neuritis attacks of BPPV. How do you manage a case of vestibular neuritis? Symptomatic treatment during the acute phase, and please bear in mind that giving vestibular sedatives will delay central compensation. Benign paroxysmal positional vertigo or BPPV is the most common cause of peripheral vertigo. Benign because it can resolve spontaneously. Paroxysmal because it comes in sudden attacks. And positional, it should be positioning because it comes with changing the position. As I said, it's the most common cause of peripheral vertigo, and it presents in the form of repeated attacks of short duration. The attack can last between a few seconds up to 1 minute, and it is provoked by changing the position, as during head rotation or during rolling in bed or looking up, and it's not accompanied by any hearing impairment. What is the pathology of BPPV? Otoconia or calcium carbonate crystals are detached from the utricle, and they migrate and float freely in one of the semicircular canals. The most commonly affected canal is the posterior semicircular canal. How do we diagnose BPPV? أول حاجة from the history, patient presenting with recurrent paroxysmal attacks of vertigo of short duration elicited by changing his position أو rotation of the head or rolling in bed. تاني حاجة by performing the positioning tests. We have several positioning tests. The most commonly used are the Dix-Hallpike test for the posterior and the anterior canal, and the roll test for testing the lateral canal. Prognosis is usually it's benign, so in most cases it resolves spontaneously within few weeks. In case spontaneous resolution did not happen, then treatment of BPPV by means of the cannulate repositioning maneuvers according to the affected canal. This is how we perform the Dix-Hallpike test for testing BPPV for posterior and anterior canals. The patient is seated in upright position. Head is turned 45 degrees toward the ear that will be that is desired to be tested. Then the patient is asked to lie down in a supine position with the head still deviated in 45 degrees and with the hyperextended neck or extended neck, and we look for nystagmus. Sometimes it even helps more if the patient is wearing Frenzel goggles to record and to see the nystagmus clearly. Meniere's disease or endolymphatic hydrops is characterized by the following tetrad. Episodes of vertigo lasting from minutes to hours, fluctuating hearing loss بيكون usually low frequency sensory neural start as low frequency sensory neural hearing loss, in addition to tinnitus and oral fullness that during the attacks. It's a unilateral disease. In other words, it usually starts by one ear preceding the other ear. In addition to the previous 4 symptoms, the patient might complain of nausea and vomiting during the attacks. In between the attacks, the patient will usually have complete resolution of the symptoms, except for some patients who might complain of sense of imbalance even in between the attacks. Some patients report the occurrence of drop attacks, what we call a Tumarkin crisis. دي بتكون it's in the form of sudden spontaneous falls without loss of consciousness. يعني البيشنت بيكون conscious during the fall, and the patient can remember the event or the episode. And as I mentioned, it's a unilateral disease, and in 10 to 20% of cases it gets bilateral, but دايما one ear is preceding the other. As we mentioned, the patient will have fluctuating hearing loss. The fluctuations are more evident during the attacks, and if we ask for a pure tone audiogram, this is how it would probably, in most of the cases of typical Meniere, will look like: low frequency sensory neural hearing loss. How do we treat a case of Meniere? This will differ from one case to another according to the severity of the symptoms and the recurrence of the attacks. But there are general measures that any patient should follow. This includes low salt diet, avoiding smoking and minimizing the intake of coffee, tea, and alcohol, and avoiding stress as much as possible. Pathology of Meniere, it happens due to increase in the amount of endolymph inside the inner ear. So whether this is due to increased production or decreased absorption. So prescribing diuretics sometimes help, and salt restriction together with salt restriction will help these patients. Also, medical treatment includes vestibular sedatives during the acute attack. Regarding the surgical treatment is needed when the medical treatment fails to control the disease, or in cases of incapacitating vertigo or progressive sensorineural hearing loss. This will depend on whether the hearing is serviceable or not. So in cases when there is hearing and can be aided, then decompression of the endolymphatic sac can be done to improve the endolymph absorption, or selective section of the vestibular nerve, vestibular neurectomy. These options are still quite invasive. If the hearing is not serviceable, or the hearing cannot be, or in cases of progressive sensorineural hearing loss, then surgical labyrinthectomy can be considered. Although right now the surgical options for Meniere disease is really getting questionable. What are the most common causes of central vertigo? We're done with the common causes of peripheral vertigo. What about the central? We have cerebrovascular disease, like a stroke affecting the posterior circulation infarction. We have the two most common posterior foci ischemic conditions, the Wallenberg syndrome, posterior inferior cerebellar artery syndrome, and the AICA, the anterior inferior cerebellar artery syndrome. What else other than the cerebrovascular disease? We have brain tumors. We have demyelinating disease like the multiple sclerosis. And finally, vestibular migraine is considered one of the causes of central vertigo.